experience and things that I've done. So you guys want to know what sepsis is, and I'm glad you guys did change because I didn't have time to change either to come here. This is going to be very laid back, but you're going to see a little bit of repetition and give you the information in a couple different ways by the time this is done. So the goal is that you kind of will recognize what the basics of sepsis is. They're easy basics, but when it comes down to it, when you put it all together, it's like, how does this all add up? So just bear with me. Who cares about objectives? But they're there. All right. So what is sepsis? Sepsis is a small word that we use, and we really don't understand what sepsis means. We know it's bad. We know people die. But how do we get it, and how does it work? In the very end, I'm going to show you a little pictorial visual of how a urosepsis really can kill somebody. It's a toxic response. So usually when I teach, I'll actually just talk about words, because a lot of times we read words and we assume that we know what it means. So does anyone know what a toxic response means? It's a toxic response. Toxic is there's a metabolism that's going on in the bloodstream that is usually anaerobic, and it's toxic to the human organism. So what's going on is not going to do anything to keep that person alive. And the longer the toxic response goes on, the more critical you are, and you die. So a toxic response can be within 2 hours. It can be within 2 weeks. It just depends on what the bacteria is and the state of affairs or the state of health that the person is in when they are exposed to this. 215,000 Americans each year. It's way more than that. It's a medical emergency, and it requires early detection and treatment for survival. So people dying from sepsis, the numbers are more and more acute than someone dying from breast cancer, lung cancer, liver cancer, pancreatic cancer, all of those added together. People are dying from sepsis more than what people are dying from cancer. It's a medical emergency because it diminishes or eliminates the delivery of oxygen and nutrients to tissues. Those again are words that you read in a book and you kind of skip over them because you skip over them. But I have a pictorial at the end that's going to really explain that. So it diminishes or eliminates the delivery of oxygen and nutrients to the tissues, cells, and vital organs. So just hold on to that thought and we'll get to it in the end. What are the causes? Well, the primary cause is usually infection, and resulting in sepsis is usually going to be the lungs, the abdomen, or the urinary tract. So when you have a paraplegic, you see a guy in a wheelchair, what's usually going to be his cause of death? Urinary tract infection. Because they usually develop chronic antibiotic resistant bladder infections. Their urine usually looks like river water by the time it gets there. There's no antibiotics that will treat it, and they will be having bouts of sepsis multiple times, and then just one time they will die. In those bouts of sepsis, they'll probably lose 50% of their body weight, almost 60 to 70% of their albumin, which then they get pressure ulcers. They have malnutrition. They have no albumin, no protein, so the drugs you give them don't have any protein to hop on to be delivered, to take care of them. So it's just kind of like a scenario. So if you have an infection in the bloodstream, it's septicemia. The bones in children, very common. Not too in the recent past, maybe it's now 4 years. There's a young boy, maybe 4 years old, fooling around in the kitchen, you know how they stand on drawers. Standing on a drawer, and he fell and he knocked his elbow. The elbow really, really hurt. He cried, so took him to the emergency room to see if he had broken his arm. X-ray was negative. Mom takes him home. It continues to be real sore. Gets, like a red, ring around with some ecchymoses from, the bruising. And just normally, this is, normal, what you can expect, to happen. To where then the elbow starts becoming inflamed, and swollen. Goes back to the emergency room. So they kind of wrap and just tell them, everything will be okay. And in 24 hours had to take him back, and he had sepsis and died. So he had no injury to the skin, but he had an insult, an injury to the bone. So young children, they can get sepsis just from the bone. The bowel is a very big one that we see, especially if you have an abdominal surgery. They develop peritonitis and get sepsis. The kidneys are a major one. Urinary tract infections or pyelonephritis. Meningitis. The liver and gallbladder love. The gallbladder loves to make people septic. The lungs, really big time with the pneumonias. And cellulitis. The common things that we watch in the hospital, and that what you are watching for, that we are all responsible for, is CAUTI, CLABSI. So we're watching IV sites, surgical wounds, surgical drains, and pressure ulcers. And with the pressure ulcers, urinary tract infections, central line infections, or IV site infections, we get no reimbursement from insurance on that if it happens within the hospital system. Our quality measures are based on that, and insurances won't reimburse us if they are acquired. Also, for certifications, like with Joint Commission, you have to be maintaining a certain percentage to be able to get certifications with the Joint Commission and so forth now. So it's a very hot item. So right here, just going and getting your nails done, or chewing your nails and getting disruption in a cuticle, you can go to sepsis just from that. And I don't know if Linda remembers, but in 799, bed 5, we had a gal who had a thorn prick. And back then we didn't really know what sepsis was. But she was out in the garden, and she got a thorn prick, and she ended up with this massive infection, cellulitis of the arm, and she did die. We also had an employee who was working out at Alpha Air Force Base, and a patient bit her. And she became septic, and all arms and legs ended up being removed, and I'll show you the process on that, why that happens from being septic. We also had in 799, bed 4, a young gal under 20 who had the tampon syndrome, toxic shock.
Don't remember.
Yes, what was it? And she ended up, we served her horribly bad. She survived. Both arms cut into like a swimsuit cut, removed, legs cut like a swimsuit cut, and all she was a torso when she left, and that was from toxic shock from tampons, which there was a real issue back in the 80s with that, and they started manufacturing tampons differently so that we did not have that tampon. Here we have a video that's going to explain this to you. And once you see this...
Our daughter Erin was 23. She had just graduated from the University of Georgia. She was going on to graduate school at University of South Florida. She went in for a simple hemorrhoidectomy on a Thursday. 5 days later, she was gone. To something I had never heard of.
Put that 400, I don't see that.
Many death certificates list the cause of death as cancer. Many of those patients die of sepsis. Many death certificates list the cause of death as complications of heart disease, and the cause of death is sepsis. Many death certificates list the cause of death as complications of pneumonia, and the cause of death is sepsis.
According to a recent poll, 7 out of 10 Americans had never heard the word sepsis.
And in fact, I practiced dentistry for 25 years, and I didn't know anything about sepsis.
We have about 1 million cases of sepsis annually in this country. And of those cases, somewhere between 20 and 25% wind up dying. There's an epidemic that is occurring in sepsis. This has been increasing in the number of cases by about 9% per year. Certain groups of people seem to be at higher risk for sepsis. That includes people like the very young, elderly people, people with chronic conditions like cancer or liver disease. People who are over the age of 65 are 11 times more likely to have a hospitalization associated with sepsis than someone who's less than 65. But there should be no mistake. Sepsis is an equal opportunity killer. It kills the young, it kills the old, it kills the sick, it kills the healthy. Sepsis is really a toxic response to an infection. So your body is constantly inundated with challenges by microorganisms, bacteria, viruses, fungi. And you have an extensive system in your body to try and keep that bacteria from becoming an infection. The problem is that body can also go haywire. And so as a result, instead of protecting you, your body actually starts trying to kill you.
The immune system is mobilized to action like an army, and the white blood cells are firing bullets at the bacteria or at the invaders. And that's fine when the bullets are targeting the bacteria, but it becomes a real problem when the bullets start flying everywhere and you get collateral damage on the patient's own organs, and this becomes a catastrophe.
So you may hear a number of terms that are used in the hospital around sepsis. There's sepsis, severe sepsis, septic shock. Sepsis is at its basic heart this notion of having systemic inflammation due to an infection. This leads, however, in some instances to people having their organs not work well. When your organs start failing, then it's called severe sepsis. If one of the organs affected is your blood pressure dropping, we call that septic shock.
Aaron went in on Thursday for elective surgery, hemorrhoidectomy, just a routine surgery. I had had it done before. And on Friday, they dismissed her for the weekend. Well, everything seemed okay until Sunday night, and all of a sudden they had a turn for the worse, and the pain level went up. Well, that's completely contrary to healing phase. So my wife took her back to the hospital. They kept her Sunday night. I went in Monday to see what's going on, and I could tell something was wrong. I could see her blood pressure was off, very low. Her heart rate was up. I said, "Where's the doctor?" He said, "Well, he's down there." I said, "Well, go get him." And he walked in. He said, "I think she's septic." It's the first time I heard the word septic. She had the infection when she came home on Friday night, but they did not give antibiotics because they told her they were concerned it would cause diarrhea. So if she would have had the code sepsis that we referred to, that is fluids and antibiotics on a Friday night, this is all preventable. And it's such a shock for that to occur and someone die from something you've never heard of. And that changed my life. I was with her when she died. She looked at me and said, with her eyes, "Can't you do something, Dad?"
If doctors treated sepsis as a medical emergency in all instances, as many as 50% of patients would survive, and so that's 100,000 people alive every year who currently are dying from this disease. We think that one of the ways to emphasize the need for treating sepsis like a medical emergency is to refer to this in the same way that we refer to other medical emergencies, which is as a code. If you're in a hospital, you might hear a code blue. That means that there's a team that responds to someone whose heart is stopped. We're trying to promote the notion of a code sepsis. And what code sepsis is, take this disease seriously. Suspect it, administer early antibiotics, administer fluids, and get the help you need to provide the care for the patient. Reducing mortality in sepsis is as easy as getting antibiotics into patients. What we also know is that your mortality goes up by about 8% for every hour that passes without antibiotics. Unfortunately, there's not a single sign or symptom that really tells you you have sepsis. But things that people could look for would be things like problems breathing, a fast heart rate, either a high temperature or chills, and blood pressure. Problems with feeling dizzy or lightheaded, particularly when you stand up, and problems with changes in your level of consciousness, either being confused or being harder to arouse. If you're concerned about sepsis, one of the things to do is, when you talk to your doctor, say, I'm worried about sepsis. That cues the doctor to think about this as a problem and do further testing.
The first time I felt the sore throat coming on, it was a Friday night. It was just like a slight soreness in my throat, nothing major. The next morning I woke up and it was the worst sore throat of my life. I actually could barely talk. I was having trouble breathing. I started running a really high temperature. I started throwing up blood. That's when I realized it was time to go to the emergency department.
And at that time, the thought was that she probably just had a viral illness like a cold leading to a sore throat. Over the next couple days, however, she got worse. Had increasing confusion, noticed her skin was mottled or had a blue discoloration, and wound up coming to the hospital a second time.
When I was admitted to the ER, they reported that I was already in septic shock. I had H1N1. I was in renal failure.
In Jen's case, her sepsis led to the formation of small blood clots in small blood vessels throughout her body. As a result of that, she didn't get enough blood flow to her extremities, and that led to gangrene, which is tissue dying.
And I do remember looking at my hands and seeing that they were black and they were curled into like a claw because they had died, but not understanding what that meant. And also seeing my feet and toes and they were black.
As a result of that, she required amputations.
I remember my mom coming into my room and saying, it's time for you to go to your surgery. And I just started crying because I felt like I wasn't going to make it through the surgery. And there was so much I wanted to tell my mom, but I couldn't talk at the time. So I just said, I'm sorry.
It's hard to really understand how sick she was. Her family was called in multiple times to her bedside because the doctors all thought she was going to die within minutes. And she was as close to death as anyone can be.
It was extremely touch and go for months.
She just slowly started getting better, but it still took her months to recover. The great unknown is the number of people who survive sepsis but are significantly disabled as a result. And those disabilities can be obvious, things like amputations, but they also can be things that are hidden, like problems with thinking, memory, calculations. Some even suffer from post-traumatic stress disorder. We feel happy that they've survived, but they're still carrying the scars around with them for the rest of their lives.
Well, I want to share my story because I've always wanted to help people, and I think this is a good way. I've always had that drive, but now it's in me even more. It makes me feel good if just one person knows what sepsis can do and how important it is to get treatment for it immediately so that there aren't great consequences.
And it all comes down to hope. That is, hope from shared responsibility that an informed public can work with their healthcare providers to reduce the deaths and disability from sepsis. The public will have to be empowered to demand and ask for early treatment. They must show that they're concerned about it, and you always have to have an advocate with you, checking everything that's done.
It is possible to improve the treatment and the survival from sepsis in the future. Will we be able to prevent any patient with sepsis from dying? Probably not. But will we be able someday to significantly improve the mortality rate of severe sepsis? Absolutely yes. But we're not there yet. We have a ways to go.
However, this is a disease we can affect today. We don't need new scientific discoveries to reduce the mortality rate by 50%.
Kind of powerful. So that is what our job is as nurses, you know, is to be that person who is always thinking sepsis. And remember, the numbers are very large, and the numbers, that is the number one cause of death at the Nebraska Medical Center, is sepsis. We have, I was on committees, and we've taken all these things, as you'll see coming up, and we put them all into order sets. We put them all into, you know, protocols. But we can put all these things into order sets and protocols, and it takes just the very basics of watching the very basic things to be aware, you know, that you're entering into a septic state. I don't think I've ever seen a live person like the young lady. All she had was a sore throat, you know. But if we would, but now we have sepsis screen in our charting, which, you know, I don't know what you guys have, but it might be something that you carry forward, you know, and see what we have done to see if you can incorporate those things into your workplace. So, who's at risk? And we're going to go through 2 more little films at the end that's putting this all together. So just sit and listen, but then there's some 2 fun videos that you watch that it'll make sense to put it all together for you. The very young, premature, and less than 1 year old are at risk. The very old, I hate saying that, it's 65 now, so I guess I'm very old. Those with a compromised immune system, wounds, are burns, pressure ulcers, trauma, injuries. Those with alcohol and drug addiction. Anyone who has catheters, tubes, chronic illness, genetic factors, and those are being treated for cancer and AIDS. But we got to remember that more than 42,000 children are developing severe sepsis each year, and approximately almost 4,500 of these children are dying. And more than the number of children who die, you know, this is more than who are dying from all of their cancers put together. I don't know what it says, you know, after they have like an autopsy or what a death certificate will say. It could say they were in renal failure, ARDS, and list all those things, you know, that were caused, you know, by the sepsis. So sepsis may not even be identified because it's multi-organ failure that they're dying from. People over 65 are 11 times more likely to be hospitalized with sepsis and likely to die from sepsis. So, what is the diagnosis of sepsis? Well, it's very easy. A body temperature greater than 38 or less than 36, a heart rate greater than 90, respiratory rate greater than 20, and a white blood cell count greater than 12,000. Patients are given a diagnosis of sepsis when they have the clinical signs of inflammation, which is SIRS. There'll be some more slides shown on that, plus a source of infection. Then you have sepsis. So sepsis may be diagnosed in a 72-year-old man with pneumonia. If he has fever, a high white count, it could be a 3-month-old with appendicitis and a low body temperature and a low white count. So you have both sides of the spectrum. So the screening tests that you're going to do for sepsis will be a white blood cell count, blood cultures, urinalysis and cultures, and a serum lactate. Then depending on what you think the source of infection is, they'll order other tests, you know, to see if you have any organ involvement, you know, for kidney, respiratory, and liver function. The lactate level is your gold standard, your icon, whatever you want to call it. And we don't do well enough in monitoring the lactate. We might get one lactate, but then we aren't doing trending. A lactate level correlates very strongly with death in sepsis. So do you know what a lactate level is? It's measuring lactic acid. So lactic acid is the end of the Krebs cycle. If you have hypoxemia and don't have enough oxygen, and it doesn't matter, we're not just talking lung, oxygen to the kidneys, the pancreas, the liver, the lungs, the brain. If you don't have enough oxygen, the end result is lactic acid. And you can do a serum lactate level. The normal should be 0.5 to 1. So why do we have 0.5 to 1? Well, you might be out running a mile, killing off some cells. And right now you're sitting on your butt for an hour. So do you think when you're sitting, there are not cells that are dying because you're sitting on them? Yeah, they are. But your body is replacing those cells. You know, you're causing some rupture of cells, some death of cells with sitting for an hour. And so you run about a 0.5 to 1. In sepsis, a lactate level at 4 or greater is considered severe sepsis. So if I have a lactate level of 4, what do you think my chances of dying are? Say you're putting it on a percentage, 10 to 100%.
75.
How much?
75.
You take your lactate times 4, and that's your chance of dying. So you have a 40% chance of death at a lactate of 4. If it comes back and you have a lactate of 8, you got an 80% chance of dying. So if you have a patient that comes back from a belly surgery, and you have a lactate level of 9, and the surgeon's saying do lactates every so many hours, and tell me what the lactate level is, you should see a decline in those numbers. Otherwise, he's going to open them up and go back in. If it stays the same, he needs to go back in. If you have a belly surgery and their lactate level is 3, and you're doing the levels, and the levels are going up, what is that telling you? You have a compression syndrome that's going on in the gut. You know, so they got to go back in and let it be. We used to do swan dances on all of our surgeries, you know, cabbage surgeries, and some institutions are drawing lactate levels because a lactate is measuring the hypoxemia to vital organs, basically. So if my lactate level is okay, I got good oxygenation, and that's what we were using swans for. How is our cardiac output? How are we doing this? If you have Dr. Howard or someone who's doing vascular surgeries in the lower legs, you know, they might order lactate levels because you're seeing if there's any possibility of hypoxemia to the organs. Lactate level will be elevated before you even see signs of sepsis or organ failure. And I'm going to show you how that happens on that little film on the very end also. So those are your tests.
Do you trend then both healthy individuals who have surgery and people going through, like, are they, if you're going to trend lactates?
I would think we should be doing more. If you do, say you have an obese gal and you put in a fempop bypass, you know, and she's laying there in bed, you know, and you got these folds and stuff, I would think someone should do training of lactates just to see how you're doing with oxygenation to that leg.
What is a trend? Like how many hours?
Oh, it doesn't matter.
It doesn't.
A lactate can change within minutes on one person and hours on another. Because it could be forming blood clots, and you could get little blood clots all the way down at the tiny parts of the toes, or someone's working on a big blood clot up above. You know, so what it's measuring is oxygenation.
What do you normally see for training? Or
Oh, you should do it like every 2 to 4 hours. But we usually get one and then don't do it. You know, it's going to take the nurse to say, can I get another lactate level? Or how about a lactate level, you know, so many hours from now? And you'll see that on the order sets. So what are the sepsis symptoms? So general things that you're going to look for warning signs of sepsis. You need to spot these signs and be able to put them all together, because what you're trying to do is prevent someone from going into septic shock. So you go from SIRS to sepsis to severe sepsis to septic shock. And the only difference between severe sepsis and septic shock is hypotension. Once you're in hypotension, you're in shock. So general things you're going to be looking for is fever, hypothermia, heart rate greater than 90, if your respiratory rate's up, altered mental status. It could be high or low blood glucose, high white count, low white count, immature cells, low blood pressure, a low CVP, low central venous blood levels, low oxygen, low urine, high creatinine, absent bowel, low platelet, high bilirubin, high lactate, and a decreased capillary filling or modeling. Like I said, we're putting all this together, but we're going to put it all together in the end. Okay, so sepsis, SIRS. Have you all heard of SIRS? SIRS is systemic inflammatory response. This is if you have a temp greater than 38 or less than 36, the heart rate's greater than 90, respiratory rate's 20, PaCO2 is less than 32, white count greater than 12,000, or 4,000, and 10% bans. Well, that's everybody in the hospital. That's every single person who comes back from the war. Everybody has SIRS. Is SIRS bad? No. It's a systemic inflammatory response. If you get the flu, you got SIRS. If you come in and you have a tympanic membrane done, it's SIRS. So everybody has SIRS. But if you have SIRS plus the presence of an infection, now you have sepsis. And then you have to have identified what this infection is. Now, if I have sepsis, which is SIRS plus infection, so now if I have sepsis, SIRS plus infection plus organ failure, or an acute organ failure, not someone who has already come in on dialysis, or a lactate greater than 4, I'm now in severe sepsis, and then I'm in septic shock if I have hypotension. So that's how you go on the scale of going from SIRS to septic shock, and there is no time limit on that. Like the gal who had the severe sore throat, she had a time span. The gal who had the hemorrhoids, she had a time span. One was overnight, one was a couple days. Sometimes our patients in the hospital, if they have other borderline things going on, or if they're over 65, or they're young, or they have multiple organ problems, they can go from SIRS to septic shock within a matter of not too long. Not too long. All right, so what we did was we made a sepsis worksheet, and I don't know, do you guys have this sepsis worksheet? I can email me and I'll send you this sepsis worksheet. We have made plasticide cards to put on our windows or in everybody's room.
We actually created a new policy and procedure around sepsis, and we created our own flow sheet. Is it signed?
Well, this is an identification card.
Okay.
So
Okay.
let me show you what this is, and then we already got the cards made. You're welcome to surely get them
Perfect.
copied. I can get one to you. I should have brought one along.
Perfect.
But what we're shown is SIRS. So if you have any two of these indicators, you have SIRS. If I have SIRS plus a source of infection, I now have sepsis. So do I have pneumonia, a urinary tract infection? Do I have a skin abscess? Do I have something in my blood, my sputum, or my urine? So if I have any of that, I now have sepsis. If I have sepsis and I'm on a med-surg floor, there is no reason why a patient can't be given their antibiotics right away and fluids. So not everybody comes to the unit because they now have sepsis. But if we go into, we now have the borderline, this is going to send you to the unit, If I now have an organ dysfunction along with it, I now am in the intensive care unit. We're gonna be putting in central lines. We're gonna be using vasoactive drugs. And then if remember, it's acute organ dysfunction, not someone that has chronic. If I go and have hypotension with a blood pressure less than 90 or mean less than 70, I now am in septic shock and I need to go to ICU. So you can treat the patient with fluids and antibiotics without going into the unit. And at the bottom, you see, this is what the card is that we have I'm talking about. It's just this card. And at the bottom has the algorithm. SIRS plus suspected source is sepsis, plus if you have acute organ dysfunction, you're now in severe sepsis, which gives you tissue hyperperfusion, and then if you have hypotension, you are now in septic shock. Okay? Sepsis order set for ICU, that comes up on Epic. So as soon as they go to ICU, those orders are not implemented on the floor. They now, we do a sepsis screen, and if we have severe sepsis, then that order set comes up, and we follow all of the orders for severe sepsis. Down in the ER, they actually are now doing a severe sepsis screen. In the ER, it's a quick little sheet where they're checking, do they have any of these? And if they have any of those, they then implement the sepsis order set. So, how do we save the lives? We've got to recognize it early. We got to do this screen for severe sepsis and shock. We got to get our blood cultures before the antibiotics. We got to make sure those antibiotics are given like within the first 30 minutes to an hour. So that is an automatic to pharmacy that those drugs have to become, they have to come up right away. And then our order set is called the early goal-directed therapy for severe sepsis. We took all the research off the line articles, what the sepsis organization says we need to have, and those were all put together and into an order set. The nurses don't have to do anything except follow the orders of what the doctors tell them to do. So there are things that we can do to prevent it, and the main thing is accountability. Accountability for, doing our baths with CHG. We have zero tolerance for not doing your hands. We are doing the CLABSI and the CAUDI. We're doing skip measures, which skip measures now is kind of a thing of the past, but in our unit we're starting to have some line infections. We do a lot of ECMO, and then this has been going on for almost a year. We thought, well, we don't do skip anymore. We don't monitor that. So they're going down and having these big hunkin' lines put in, and we're treating them just like you're getting a line put in. So we're going back to look like we got to bring skip measures back for insertion of lines for ECMO. You got to prevent the pressure ulcers and CAUDI. We now at the hospital have to do a playback every 6 months on how to do peri-care and Foley care and catheter care. And it has to be documented and put into the chart. And they have to do once a year online training on how to do catheter and peri-care. And with doing that, our rates have come down quite a bit. The minute we don't do it, our rates start going back up. So the early goal-directed care, these are bundles. They're little bundles of orders that we're putting together. And what we're getting is our key lab values. We're identifying what the source of the infection is, what antibiotic, and we have infection control stewardship, where antibiotics and infections have been matched, and the doctors have to follow kind of like the recipe of what we're using at the med center. We got to make sure that we get that fluid resuscitation started right away. They're getting a liter of fluid right away. And controlling the blood pressure, making sure that we keep it up. If we have blood pressure up, we keep them from going in shock. We have less problem with tissue perfusion issues. Got to control the blood sugar. When you go into sepsis, you can either have a high or a low blood sugar. Usually they run high. Sometimes we have to sedate them and intubate them. Sometimes we have to start the dialysis right away. So if they come into the ED, they have to have antibiotics within 3 hours. There's chart reviews on that we cannot fall out of those parameters. But if you are on the floor as a patient in the hospital, it has to be in less than 1 hour. And those criteria are followed very, very closely. In 3 hours, the first 3 hours, they better have their lactate level done. They gotta have their blood cultures done. They're on a broad spectrum antibiotic, and we're giving them crystalloids or colloids or fluids for their blood pressure. In 6 hours, if they're still failing, we gotta have the vasoactive drips on. If they have persistent hypotension and they're in shock, we gotta be making sure that we keep that lactate less than 4. If it's greater than 4, we gotta get CVP lines in, we're measuring their SVO2, and then we're remeasuring the lactate. So it is a very critical, special scenario that we go through. We had a lady, I'm gonna just go through this real fast. We had a lady, a 59-year-old, who came in to the 8 tele, and she was complaining of abdominal pain for about 2 months. And her medical history had that she had an abdominal aortic aneurysm, she had diabetes, had a right nephrectomy, she was on hemodialysis, she had coronary artery disease with a stent, she had heart failure and COPD. So I mean, this gal is a very marginal lady to begin with. But her vital signs were okay. She was 104/59, everything else was looking okay. Her white count was 25.2. Her hemoglobin was 9.6. Glucose was 111. And they called for the vascular and the GI guys to come, but they recommended no surgical intervention for AAA at this time. And now we're at 6 o'clock in the evening. She went to radiology. Vital signs are still okay. They started her on her Coreg and the rest of her drugs. But at 9 o'clock, almost 10 o'clock, she's still complaining of this bad abdominal pain. It was 8 out of 10. And a little bit later, an hour later, her blood pressure is 79/52. So she's put in the Trendelenburg position. She's alert, she's oriented. Denies any symptoms with her low blood pressure. The physician comes in, orders a fluid bolus of 500, and he's called back at the bedside, about 10 minutes later, blood pressure 65/41. It keeps on going at almost 1 in the morning. She still has a systolic blood pressure of 70 to 80. He gives her another liter of normal saline and another 500 of saline, and she's still a 73/51. She has no urine output. He gives her another 500 of normal saline. Blood pressure is still 74. Gives her another 500 of normal saline, and he can't get that blood pressure up. So she ends up going. Pardon?
She's in renal failure on dialysis.
So
she's not gonna have a urine. Okay.
This actually happened on our floor.
Okay, I'm just commenting.
Yeah. So then they send her back to CPCU, and the transfer note says septic shock. So he gives her vancomycin, and he's getting a little bit nervous here. So she comes back at almost 3 in the morning to 8:50, and they're putting her on Levofed. Morphine IV was given. She had no urine output with a straight calf. They put down an NG. At 4 in the morning, she's wheezy. They're trying to give her treatments. At 4:10, she codes. And she, of course, dies. And all of that was, this is the code. We gave her epi. She's in PDA, epi, PDA, 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 and she expired. And so, what happened? I mean, she dies because it was unrecognized septic shock. We waited all night long. giving her boluses and boluses and boluses. No one's asking the question, like we're in renal dialysis, and with all that fluid, she's still not got blood pressure. So these things do happen in the hospital, and so it took him that she was in septic shock, because that's the only thing that's left, because he can't get the blood pressure up. So the most frequent clinical signs just before code are usually the clinical signs that we should have been measuring in the first place, warranting us that we might have, sepsis going on. It's usually always like an acute respiratory distress. So the most frequent early clinical signs in the hours before code is the respiratory rate, the O2 sat, the level of consciousness in urine output, and these are the things that we should be following and trending, in our charting system, and it should be clicking, do we have SIRS, do we have sepsis? So since we recognized that, we started putting sepsis screen in all of our charting, and that still wasn't helping us too much. So now if we put those in and more than one clicks together, it's bringing up a flag saying, do a sepsis screen. If we do a sepsis screen and then it rates us in what level of, are we SIRS, sepsis, or severe sepsis, it automatically tells us they gotta go to the unit, we gotta start an order set. Because all of this is still taking us a long time to understand sepsis. So what we did, I know you don't have this charting, but this is just like an overview of a patient's summary. And what we're looking at is the vital signs. It's the vital signs that's your SIRS signs, right? So if you are trending with your vital signs, and then you say, oh, I got a sign of infection somewhere, and oh, my kidneys aren't putting out any urine, you're in severe sepsis. So with this, we incorporated all these things into a sepsis screen, and it helps us look at our trends. And you don't have any of this charting, that we do, but this is what this is all doing for us. And vital signs, and we tab, and right here you can see where it's keeping track of our sepsis screen score, and it sends us all kinds of flags of what we need to do and take care of our patient. And then we thought, well, we're still not doing well. So then we started putting sidebars in right along the report of what's SIRS, what's sepsis, what's severe sepsis, what are the indicators we're looking for, so that the nurse then can look at all of that information along with her charting. And we're doing better. So that sepsis worksheet right there is in a plasticized card, and like I said, I can very gladly send it to you. And you guys can surely copy that off for yourself. So when you're doing a screening score, if you have a negative screening score, you don't need to call the doctor, you don't need to do anything. But if changes in the vitals and labs and status happen, you gotta go back and do another sepsis screen. So just because you do one on a shift, or you do one, and you start getting a temperature, or your heart rate's going up, or respirations are going up, then you go back and do another screen. So you gotta do your SIRS screen. So you still don't have to call your doctor for SIRS, but SIRS is normal in many conditions. So then this is where you start watching. And then all of a sudden, if you say, okay, my first sepsis screen is saying, yes, I have it, I'm screening only, but if now I'm showing that I see signs of infection, you gotta give that antibiotic in less than an hour, and you gotta give them their fluids, and then you gotta really watch them. Is there any changes in their respiration? Is there any changes in their other organs? And they might need other labs, to track them. They can stay on the floor, but if they have any changes in that, you're now in severe sepsis, and they gotta go to the unit. We gotta put in big lines, give them fluids, monitor the CVPs and the vasopressors, and we hope the status will improve. But just because we get them early doesn't mean that we can change that around either. It's just like the gal that came from Carney. She had a lot of things that are going on. Most likely we would have not have been able to change much, but just because she had a AAA and she was on dialysis, and had COPD and congestive heart failure. We assumed all those things were kind of normal for her, but she was not any of those diagnoses. She was sepsis, and she died from sepsis and not from those disease states that she has. So always evaluate for SIRS. You don't have to do any of that. You don't have to do any of that, or that, or that, or that. So we're going to click through these because I have some stuff in the end. So your severe sepsis screening panel, get blood gases, your CBC, your metabolic profile, check the lactic acid, and get your ProTime and INR. And we screen our patients. Every patient gets screened at 0800 and 2000. Twice every day, 08 and 2000. And if there's anything that change, we got to go back and do another sepsis screen. So when we're looking at our vitals, we're making sure is the fever going down, is the blood pressure going up, is there changes in our oxygen? We already kind of went through that. So,
What if you can't find the cause of the infection? But you know that they have indicators that they have sepsis?
your cultures aren't going to come back, right away. You got to get the cultures first, and they go on broad spectrum antibiotics. If those broad spectrum antibiotics are not working, and we still aren't getting anything back on cultures, we have like the infectious disease on the case, and they're making a guess like, well, you can always smell Pseudomonas.
Oh, yeah.
You might have a nurse saying, they got Pseudomonas, I can smell that down. Or, well, they might, they have an algorithm, they have protocols of what they would go, they'll look at the history, like if someone is on dialysis, well, maybe in that subgroup of people, they tend to get this kind of bacteria. In a paraplegic, in that subgroup of people, they're usually antibiotic resistant. If someone has MRSA, we should probably be looking at this. So they use their intelligence and make educated guesses on what they need to do next. I had, at the very
I
end,
think what she was asking, Jen, is can you tell what the primary source is?
If you can't find the source of infection, then you just go by, she answered exactly what I was.
Oh,
yeah,
I just wanted to
Don't,
make sure.
Yeah.
and find the
because
source.
it's
don't know
happening
what it
so
is.
fast, you may not know what, like a young boy with the elbow, who would guess that that boy was gonna die from
If they have the
sepsis?
Or sore throat.
Or the sore throat. She had H1N1, and so she would have shown those beginning signs of sepsis on that first visit. She would have,
Treated, you don't know what the source
they
is.
would have had the SIRS plus infection, and if they would have started the sepsis protocol, they would have not had to wait until she was. Now I have, by the end I want to see all my slides. You guys have a different thing at the bottom. So let me go all the way to the bottom here. So you can get it.
As a mother, I'll probably be taking cold with ER first, but which one you can.
Oh, there you go.
Maybe when I thought she's in a trade.
We're all gonna be
You need some help. Let's go to the internet. And let's do, put in Sepsis Symptoms. Here.
Our daughter Erin was 23. She just graduated from the University of Georgia. She's going to graduate school, University of South Carolina.
Here, I'll sepsis YouTube.
I know, in the old days, we would have that profile.
Sepsis, I think YouTube. Okay, let's do the second one. Okay, we're gonna watch this one. You might have to. Yeah, there you go. Okay, this is gonna show you actually what's going to happen here with sepsis. And of course, it's showing you got your urethra, there's your bladder, there's your ureters. It's kind of given kidneys, lungs, heart. A local infection can spread and lead to sepsis if it's not timely treated, and this is exactly what we're talking about. So you got bacteria that is down in the vaginal area, and the bacteria now is going to enter and it's going to give you a bladder infection. It's going to go up the ureters, and we are now into the kidneys. And it shows the presence of a urinary tract infection here. And now that we're in the kidneys, it's going to show you, here's all the bacteria that you have, now in the kidney. This bacteria begins to multiply, and then it begins to get into the bloodstream. So when the bacteria now gets into the bloodstream, this is what we're going to call sepsis. So it migrates across, it gets into the bloodstream, and now you're in the bloodstream. And this is where the guy was saying that you're shooting bullets, and the bacteria is now releasing an endotoxin. This is the poison in the bloodstream. And you're going to see that this endotoxin, as the bacteria ruptures, the white blood cell reacts to the presence of the bacteria. So when these white cells target them, it's going to eat them up. But the white cell can't do everything because it's releasing the endotoxins. And as those endotoxins are released, it now is going to start a reaction within the body. The toxins may be released when the bacteria enters into the bloodstream. So now you've got these endotoxins, and now this is going to go up into the lung because the blood goes through all organs. So when we're in the lung, we've got infection now coming into the lung. You're going to get low blood pressure because now it's affecting not only the lung but the other organs. And what's happening in the lungs, you start having exudate form, fluid leaks into the lung, and the oxygen cannot migrate across. So fluid is present, and the fluid decreases absorption of the oxygen. So now you're going to begin to see there's no organ damage yet, but this is where the beginning of your lactate can start going up. Here it's showing you normal oxygen absorption and compromised oxygen absorption. You only have one or two little dots there. That is what we're calling, ARDS, and they're intubated and put on the ventilator. So now you have this bacteria. It's still circulating through the body. You're getting fluid leakage in the lung. There's less oxygen being carried to the other organs. So you're in lung failure. And then sepsis causes the kidneys to fail. So now you have damage to the kidneys. You're going to have to end up on dialysis. And as the kidneys are failing, you have all these endotoxins and bacteria floating into all your blood vessels. And as you float, you're going to see changes inside the blood vessels. These are your red blood cells, and now the red blood cells are going to start, you hear about consumption of platelets and consumption of clotting products. You start clumping. It doesn't matter if this is a big vessel or the tiny vessel on the fingers and the toes. It causes clots to form in the blood vessels, and it chokes them off. you have no blood supply. That's how the gal lost her fingers and her toes and her arms and her legs. And that's how they start, you know, when she came in, her hands were cramped and black. This is what happened. So it starts in the tiny vessels where it closes off first. So now you have decreased blood flow to the extremities. And this is kind of a typical sepsis event. So you have ischemia and necrosis in the fingers and toes, death of tissue, and your lactate level will rise as more and more of these tissues are destroyed, and more there's lack of oxygen to the cells. So if you fail to treat the urinary tract infection, you now just cause them septic shock with multi-organ failure, which is the lungs and the kidneys, and you have we have kind of gone through all of that. So I'm going to let you get me out of that, but don't get me out of don't get me out of the YouTube, because I want to show them another YouTube below that.
And I know a couple of you have to go to work, so go ahead.
Am I too long?
Nope, I think
I wanted to show you
one more is fine.
You know,
But if they need to go to work.
just so everybody knows, you'll get a Survey Monkey from the Med Center, from Nebraska Medicine. And it always asks, was there a disclosure? There's no conflict of interest with this presentation.
Okay, I can't go down. Not so fast. Go up to the yellow. Well, you need to go to the next page, and there's something that will sum this all up.
Sometimes it's just if you go to, sometimes I find this easier.
What seems to be the problem here?
Well, I went to visit my dad in
That's
the
not it.
nursing home today. Is that one not septic back? Right.
Our daughter Erin was 23.
Yeah, but it
She
might
just
come
graduated
after
from
that.
University
Is
of
there-
Georgia. She was going on to graduate school, University of South Florida.
Oh, it sounds about
She went in for a simple MRI
There you go.
on a Thursday.
I give you time.
Sorry, I didn't even notice you had it on when you went through.
Something.
Yo,
Hold
to
on.
what I say, the mercy sepsis.
Sorry.
And then turn up the sound a little bit
Hold
so
on,
they
yeah.
can hear it.
I need to get out of this one.
Now listen, y'all, to what I say. The mercy sepsis team is here to play. We're working all day and through the night to eliminate the bugs that put up a fight. The first place to change was emergency, where the sepsis bundle was the key.
Yeah.
They got their lactate and cultures off the bat. Antibiotics makes those bugs go splat. When the blood pressure dropped or the lactate was high, it was time for fluids, so else they may die. If this didn't work, the pressers didn't wait to keep the CVP greater than 8. The SpO2 was our last measurement. We did all we could to keep it over 7%.
Go sepsis, go sepsis, go sepsis.
Go sepsis. Now here we are in the ICU, where the first thing we did was a chart review. Communication was the word of the day, with education to teach the sepsis way. Steroids, Ivers, glucose control, helped us reach our final goal. And the last but not least was the RRT, prioritizing treatment that was meant to be. So listen up and follow our lead. With the sepsis program, we hope to plant the seed. Sepsis, yeah. Sepsis,
They kind of just sum it all up. There you go.
I know.